Hey there, I'm Professor McBride, labor nurse, OB instructor, and your guide to everything OB. Let's get to it. In the postpartum period, we primarily focus on specific areas for evaluation: the breasts, the uterus, bladder, bowel, lochia, episiotomy or laceration, Homan sign, thinking about hypercoagulation, and emotions and bonding. With the breasts, the first couple days after the baby is born, the breasts are soft with colostrum. In days 2 to 3, they begin to fill, and by days 3 to 5, the milk should come in. So the breasts will feel full but soften with breastfeeding. Prolactin is the hormone that triggers milk production, and oxytocin is what helps the milk let down. And so it forms a supply and demand give and take. It's important to initiate breastfeeding in the first 1 to 2 hours after birth and assist with proper positioning and latch in order to help minimize tissue trauma to the nipples. Promoting breastfeeding with every feed will be important unless she's choosing not to breastfeed. If she's not going to breastfeed, we will educate not to stimulate the breast at all, because every time the breasts are stimulated, the milk will let down and she will make more. So, signs of potential complications related to breastfeeding. Firm and tender breasts could be engorgement. And so, when the milk first comes in, the body makes a lot. We haven't figured out our supply and demand. And so, the breast can become very full and taut and uncomfortable. Promoting breastfeeding will be helpful to release this pressure or hand expressing. A supportive bra is helpful. Warm water, like a shower, will help the milk let down and relieve some of that pressure. Ice packs between feedings can help with that inflammation. Cabbage leaves can also be helpful for this, and this is typically going to last about 24 to 48 hours. Sore, cracked, or blistered nipples are probably caused by an improper latch. So this is why it's very important to assist with positioning and get that nice deep latch from the very first feed. We can provide comfort measures like hydrogel pads to help with nipple soreness and lanolin to help with healing. If she's experiencing a fever and flu-like symptoms and unilateral breast pain, especially with a hot reddened area, these are signs of an infection called mastitis. This probably will require antibiotics. We want to encourage her to continue to empty the breast, and it is very safe for the baby to still feed on that side, although probably uncomfortable to do so. So she can either latch the baby on that side or pump that side, but she should still empty the affected side in addition to the unaffected side. Warmth will help again with milk let down, so a nice warm shower could be helpful. Supportive bra, analgesics, and anti-inflammatory medications. If she's experiencing swollen and tender breasts that have no fever and possibly a little white pearl at the nipple tip, this is a sign of a plugged milk duct. With a plugged milk duct, frequent feeding is helpful. Feeding on the affected side first, massaging the affected side while feeding or pumping, all can help release that plug. For the uterus, the normal finding would be a firm fundus. Once the baby is born, the uterus should contract and squeeze and stay contracted, so it should feel firm on palpation. It should be midline and at the level of the umbilicus for the first 24 hours. Normal involution is if the uterus is going down about 1 centimeter per day. Signs of potential complications: if the uterus is soft, foggy, or higher than that belly button landmark, these can be signs of uterine atony. Uterine atony is the #1 cause of postpartum hemorrhage in the first 24 hours, so it's very important that we manage this. Deviation from the midline can be caused by a full bladder. The bladder gets full, it puts pressure on the uterus and can cause it to deviate to one side. This can also contribute to uterine atony. Failure of the uterus to return to its non-pregnant state is subinvolution. So since it's supposed to go down about 1 centimeter per day, if that's not happening, that's subinvolution, and that's typically caused by retained placental fragments or perhaps infection in the uterus. If she has sudden pain and you cannot palpate the uterus, this could be a uterine inversion where the uterus is actually turned inside out and down into the vagina. This is an emergency for hemorrhage and it is going to need to be replaced. So they give medication to relax the uterus and they push it back up and then quickly give Pitocin to make it contract. For the bladder, we would like to have spontaneous voiding within 4 to 6 hours after delivery so that the bladder doesn't become too full. We do not want it to be distended. We want her to be able to empty completely without difficulty, and diuresis is going to begin about 12 hours after delivery. So it's going to be very helpful if she's voiding well prior to this, because when she starts diuresing, she'll be producing a lot more urine. And we don't want that bladder to be too full. Signs of potential complications: an overdistended bladder. An overdistended bladder can put pressure on the uterus and cause uterine atony, which can cause hemorrhage. We can also have bladder stretch injuries if the bladder's too full. Stress incontinence is a separate issue that happens that we can teach Kegel exercises to help improve. Frequency, urgency, or burning can be signs of infection, so this is something else that we will be watching for as well. With the bowel, it may take 2 or 3 days for normal bowel evacuation to resume. In the meantime, we need to encourage things that are going to promote normal elimination. So ambulation, hydration, fiber. Signs of potential complications for this is related to a risk of constipation. Also, if she has an injury to her anal sphincter from a 3rd or 4th degree laceration, she has an increased risk of bowel dysfunction as well. L is for Lochia. Normal Lochia in the first 1 to 3 days is Lochia rubra. Lochia rubra is red. It could be scant to moderate in volume and have a fleshy odor. These are normal findings. Days 4 to 10 will be Lochia serosa, where now instead of that red color, we are more pinkish or brown, like old blood or mucusy. And then from day 10 and beyond, we're going to see a white or yellow discharge, and this is Lochia alba. Signs of potential complications related to Lochia would be heavy bleeding or large clots, and these are signs of uterine atony, which again is the #1 cause of postpartum hemorrhage in the first 24 hours, so very important to assess. If she's saturating more than a pad in an hour, this is an indication. This is too much. Also, if there's a foul odor, this is a sign of infection, so this is something else to be mindful of. Episiotomy or lacerations. This is looking at her perineum. If she had an episiotomy or a cut in her perineum, or if she had a laceration, it should be repaired and it should be approximated. There might be some edema and minimal to moderate discomfort in the area. So this is where we can offer comfort measures like ice packs, sitz baths, rinsing with a peri bottle. She can use witch hazel pads, benzocaine spray, and things like that to help with that discomfort. We want to prevent constipation. We don't want her to have hard, large stools coming through and disrupting that delicate tissue. If she has significant tearing that is 3rd or 4th degree and close to the rectum, then no suppositories or enemas can be used. Signs of potential complications would be redness, odor, significant pain, purulent drainage, or wound separation. So these could be signs of either infection or signs that it's not healing properly. The other thing that we might see with the perineum could be a bluish purplish swelling with significant pain. That could be a sign of a hematoma. And when we're assessing the perineum, we should also assess the rectum and notice if there are any hemorrhoids. And if they are there, they should be soft. H is for Homan sign. Homan sign is a way to assess for a DVT. And we don't often do Homan sign anymore because if a DVT does exist in the calf and we are manipulating that leg, we risk dislodging the clot. So we're going to still think about H as also hypercoagulation. In pregnancy, a woman is hypercoagulable and she's still hypercoagulable in the postpartum period. And so signs of potential complications. If we have unilateral leg pain, tenderness, swelling, redness, or warmth, these are all signs of a DVT or deep vein thrombosis. This is the most common during pregnancy and would need to be treated with anticoagulant therapy. If there's lower extremity pain and tenderness, and you can palpate an enlarged and hardened vein, this could be a superficial venous thrombosis. This does not need anticoagulant therapy. This can be treated with rest, elevation, compression socks, and nonsteroidal anti-inflammatory drugs. If we see dyspnea and chest pain and tachypnea and tachycardia, these are signs of a pulmonary embolism. This is an emergency because the DVT, the clot, could travel and lodge in the pulmonary artery and obstruct blood flow to the lungs. This also would need to be treated with anticoagulant therapy as well. Early ambulation is going to help prevent the formation of clots. So getting the mom up and moving is going to be very helpful to keep this from being a problem. For emotional status and bonding, normal would be excited and happy and involved. We can see attachment and bonding by watching the mom interact with her baby and take care of her baby with feeding and diapering and talking to the baby and swaddling and touching and all of these things. During this time, we also might find that the woman is experiencing some emotional lability, and this typically peaks around day 5 and subsides around like day 10. And she might say that she's not resting well or she's crying easily, she might feel moody, and this is typically baby blues. This does affect up to 85% of women, and it doesn't interfere with her functioning or with her ability to bond with her baby. And so it resolves on its own. Signs of potential complications could be if the mother is having significant anxiety and sadness and tearfulness, and especially if they're disinterested in their baby. These are signs of postpartum depression, which is a much more significant finding. These symptoms will be worsening and last longer than 2 weeks, and often they require intervention in order for the mother to finally feel better. More significantly still is postpartum psychosis. Postpartum psychosis typically affects women who already have a diagnosis of things like bipolar disorder, but it doesn't have to just be that. Oftentimes it will onset around 2 to 4 weeks. It comes on quickly and it has significant symptoms of hallucinations and delusions. These are the ones that have the significant safety issue because these women can and will hurt themselves and their babies, so they need immediate intervention. So our physical assessment during our postpartum period focuses on the evaluation of these specific areas: the breast, the uterus, the bladder, bowel, lochia, episiotomy and laceration, Homan sign and hypercoagulation, and emotional status and bonding. Thanks for watching. Be sure to subscribe, like, and share for new videos every week about everything OB. See you soon.